Hi everyone, thanks for listening to my presentations. Today I'll be talking about acute kidney injury. It's also known as acute renal failure. Okay, sit back and let's go. Acute renal failure or acute kidney injury is a sudden drop in the function of the kidney. Sudden drop. And that will lead to retention of the urine, accumulation of urea, accumulation of creatinine, altered ECL volume, and electrolyte imbalance. Acute kidney injury was formerly known as acute renal failure. There is no complete organ failure yet, but we'll be dealing with a small decrease in renal function. However, it may lead to increased morbidity or mortality. To make the diagnosis of acute kidney injury, there's a new diagnosis system now known as KDIGO, that is Kidney Disease Improving Global Outcomes. KDIGO staging system is the most recent and of course the preferred. You can also come across, through the literature, you can come across risk injury failure, loss of kidney function, and end-stage kidney disease, which is RIFLE. And also you can come across the modified RIFLE, which is the AKIN, that is Acute Kidney Injury Network. But for the purpose of this presentation, I'll be walking through the diagnosis using KDIGO, that is KDIGO, Kidney Disease Improving Global Outcomes. Going by KDIGO, you can make diagnosis of acute kidney injury if you are dealing with increased serum creatinine greater than 0.3 mg per dl within 48 hours, or increased serum creatinine up to greater than 1.5 times the baseline within 7 days, or you have the urine volume less than 0.5 ml per kilogram per hour in the last 6 hours. You could also get your diagnosis using KDIGO, but we have to assess the volume status and take into account the obstructive causes and also correct appropriately before concluding on the diagnostic criteria. Now, staging criteria. Stage 1 will include increased serum creatinine 1.5 to 1.9 times the baseline, or increase in serum creatinine by greater than 0.3 mg per dl, or reduction in urine output up to less than 0.5 ml per kilogram per hour for about 6 to 12 hours. Stage 2. You will arrive at stage 2 if you have increase in serum creatinine up to 2.0 to 2.9 times the baseline of the serum creatinine, or reduction in urine output less than 0.5 ml per kilogram per hour greater than 12 hours. You will be dealing with grade 3 if you have increase in serum creatinine up to 3 times the baseline, or increased creatinine greater than 4 mg per dl, or you have decreased urine output less than 0.3 ml per kilogram per hour in 24 hours, or you are battling with anuria for more than 12 hours, or you have the reason to initiate replacement therapy, or you are dealing with an individual less than 18 years old, but the glomerular filtration rate is less than 35 ml per minute per 1.73 meters squared. If you are dealing with any of these, then you are at stage 3 of acute kidney injury. What are the possible limitations to KDIGO? There are multiple etiologies, but KDIGO has not taken care of that. Acute kidney injury is not a single disease, and patients should be evaluated for pre-renal acute kidney injury and acute tubular necrosis. Reversible causes like obstruction should be treated promptly, and serum creatinine level is more significant than urine output in mortality prediction, but some other experts believe otherwise. Still on limitation, oliguria may be due to insufficient rehydration, so volume of urine is difficult to be used as a criterion. The baseline creatinine is difficult to estimate, right? It is difficult to determine the baseline creatinine. Many times, no record of the baseline creatinine before acute kidney injury occurs. So, admission creatinine that may be reasonable as the baseline could be, and I want you to get this, could be the average of values between 7 to 365 days. Please tell me a doctor who has done that before. Can you take average of creatinine values every day for at least 7 to 365 days? No. Other investigations that we'll quickly run through will include complete blood count, electrolytes, glucose, liver function test, thyroid function test, urine microscopy, culture and sensitivity, toxicology. And remember, we've been dealing with blood, urea, nitrogen, and creatinine already, and of course the volume status. Then you can have your ultrasound done, KUB, or CT scan. Treatment. First thing is prevent. So prevention can include to prevent hypovolemia with normal saline by adequate fluid administration. For example, you can give 10 to 20 ml per kilogram over 30 minutes. Anotropic agents could be administered to prevent hypotension. We have to stop or adjust nephrotoxic medications. For example, if the patient is on aminoglycosides, amphotericin B, contrast media, or cisplatin, acyclovir intravenously should be suspended, while tumor lysis syndrome should be taken care of. And we have to measure the drug level at the same time that we're measuring the creatinine or blood urea nitrogen. Still on treatment, the pharmacological agent could include mannitol. Mannitol is osmotic diuretic, right? It could decrease intratubular cast formation, but its use is controversial. Some will use high-saline diuretics like laces, but note this, it may lead to increased creatinine in the serum, may actually increase the risk of acute kidney injury, so don't use laces. Some will use dopamine, but please don't use it. Phenoldopamin will increase urine output and decrease blood urea nitrogen. Some will use natriuretic peptides. Either natriuretic peptide or B-type natriuretic peptide will vasodilate afferent arteries. It can block sodium tubular reabsorption and increase urine output, thereby decreasing blood urea nitrogen, but is not routinely used. N-acetylcysteine is an antioxidant agent. It has vasodilatory effect, but used mostly in acetaminophen toxicity as an antidote. Not routinely used, but it is used in prevention of contrast nephropathy as well. So somebody is having acute kidney injury after you have prepared the patient for an radiological investigation, please go for N-acetylcysteine. Or the history of acetaminophen toxicity, Tylenol, or paracetamol, depending on where you are on the surface of the earth, is already in this patient. Please go for N-acetylcysteine. IV fluid. Yes. Assess the fluid status before giving the IV fluid, because that would determine what level and what you can get. If this patient is hypovolemic, you can give normal saline at 20 ml per kilogram over 30 minutes. If volemia, then consider the insensible fluid loss due to respiratory system or sweat. And of course, consider the sensible fluid loss through the urine or defecation via the gastrointestinal tract and replace the same. If hypervolemia, evident by auscultating and picking crackles on the lungs, that is pulmonary edema or edema peripherally, or heart failure, then you should treat with diuretics. So at that stage, it will be fine that you are dealing with acute kidney injury, but you are picking hypervolemia, you are picking pulmonary edema and peripheral edema, then you can grab your laces. Critically ill children can have renal replacement therapy to take over the function of the kidney. And of course, electrolyte replacement, and we have to treat increased potassium. It depends on the value of the potassium that will dictate what we can do. It's not all the time we'll go for calcium gluconate and go for insulin, go for salbutamol, with glucose and caecylate and so on. It depends on the value. You can get that through my channel here. I have published hyperkalemia treatments. You can just Google and get that far. We have to correct metabolic acidosis as well. If you are dealing with hypertension, you can give diuretics and antihypertensives, but you have to be careful the type of diuretics I'm going to select here. Potassium sparing will increase the level of potassium, and when you're dealing with antihypertensives, like angiotensin converting enzyme inhibitor, might not be welcome here unless you have ruled out all causes of the acute kidney injury. Nutrition. Now, dietitians will be involved because the goal is about 120 kilocalories per kilogram per day, and you monitor and control glucose. Enteral feeding first, but if that is impossible, then you can have total parenteral nutrition. Note: monitoring is required if the patient is on vancomycin, aminoglycoside, enoxaparin, or digoxin. Renal replacement therapy will be involved when there is fluid overload, and the fluid overload is not responding to diuretics, or you're dealing with hyperkalemia greater than 6.5 milliequivalent per liter, or the uremia, blood urea nitrogen is between 80 and 100 milligrams per dl, or you have pulmonary edema, heart failure, or hypertension. Renal replacement therapy could involve hemodialysis or peritoneal dialysis or continuous renal replacement therapy in multi-organ failure or hemodynamic instability. The prognosis is such that mortality is a possibility and is very high. Mortality is higher in infants, is higher in those with concomitant morbidity. Morbidity that could increase mortality here would be possible chronic kidney disease later in life, including end-stage renal disease, hypertension, or massive proteinuria. Follow-up. There's need for a long-term follow-up, and that will be proper. Thanks for listening to my presentations. The next presentation will be on chronic kidney disease or chronic renal failure. I appreciate your time. Please remember to subscribe and share. I appreciate it.